But if the stent is 3 months, 6 months or older, then you can birth the stent if you just go through the stent. There is a chance of birth entrapment in the stent. You always have to recognize that. But if it's an older stent that is periodized, you can birth it, it will particularize the lesion as well as the stent. So when, for this laser, you don't have laser, so you can use when you start the stent, then you have calcified single lesion. This person should be healthy, should not be very tall. This patient should be very stable. For say, a 175 bird that situation or 655 vessel. It's a larger bird that has to go through smaller lesions. So versus you take a 1.5 grade, you cover that data. So it's back, when you put it back, it's not that much. I will stop the bird in the region, always bring it back. For dominant circs, sometimes I will, sometimes I won't if there's a...
Then this system, इनके थोड़ा सा इनको connection will check it. और दोनों ये आपके उसमें before going in the system, before pressing the Y connector to go in, okay, आप direct light पे check करके इसको वापस उस पे कर लेंगे rotations पे. आप अभी आपको मैं बताऊंगा कि अल्ताफ साहब इनको थोड़ा गाइड करेंगे किस तरह से एक single press से it's changes its mode. इसको ऑन कर. Sorry, and this is the knob for RPM selection.
We have to.
It's simple like this. It's something like knob.
Counterclockwise, reduce the RPM and clockwise we can
RPM. Next, this is the cylinder. Thank you. This is the console, and now this is your solution. नॉर्मली हम रोटा ग्लाइड हमारे पास यहाँ नहीं आता, अवेलेबल नहीं है पाकिस्तान में, है कराची वगैरह में आई डोंट नो, लेकिन हमारे पास पंजाब में तो नहीं है. तो हम इस नॉर्मल सलाइन में क्या क्या डालते हैं?
हेपरिन
ओके, वो हम इसमें डाल देते हैं. अगेन अगर आपके पास प्रेशर इन्फ्यूजन पंप है, गुड. व्हाट वी आर डूइंग इफ यू डोंट हैव द प्रेशर इन्फ्यूजन पंप, हम बीपी कफ लेते हैं और बीपी कफ को इसके ऊपर लाइक वी आर डूइंग इन इमरजेंसी इन ओल्ड डेज, तो जिस तरह इसके ऊपर बीपी कफ लेके इसके ऊपर प्रेशर जनरेट कर देते हैं. ओके, ताकि ये जो है उस पूरे सिस्टम के अंदर से थ्रू प्रेशर इसको ड्रिपिंग इसकी सिस्टम को कंटिन्यू रखे, ड्रिपिंग शुड नॉट ड्रॉप. ओके, ये हो गया सिस्टम, और ये बीपी कफ से अभी भी बीपी कफ से ही अटैच किया हुआ. ओके, अब ये रोटा वायर है. ओके, हम इसको खोल सकते हैं.
दो टाइप्स के बारे में, एक फ्लैटी होता है, एक हार्ड.
जी,
उसका क्या हम किस तरह सोल्यूशन करते हैं?
आई डू इज मैं तो इसको फ्लॉपी ठीक है, हार्ड वायर कुछ लोग यूज करते हैं फॉर एनी, यानी कि बहुत ज़्यादा कॉम्प्लेक्सिटी हो या बहुत आपको बीच में उसको वो करना पड़े, मैं हार्ड वायर यूज करता हूँ. तो फ्लॉपी वायर इसको फीड कर, इसके ऊपर कोटिंग नहीं है, दैट्स वाई इसकी ट्रैकेबिलिटी बहुत पुअर ट्रैकेबिलिटी है. इसलिए हमने उसको इस जगह पे जाने के लिए माइक्रो जो भी है,
ये इसका बैक एंड है,
ये बैक एंड है, फॉरवर्ड से भी इट्स नॉट कोटिंग है थ्रू आउट. इसमें आप देखें इसका डिस्टेंस सिर्फ सॉफ्ट है.
वाइट क्लिप भी इनको बता रहे हैं इससे हम कंफर्म करते हैं.
फिर वो कुंडली वाली तरह जाता है से
जी,
कुंडली वाली तरह फिर है.
जी जी जी. उसके अलावा अगर आप फील करें, इट्स डिफरेंट फ्रॉम द योर वर्क क्रॉस वायर. और ये उसका फिक्सिंग क्लिप है जो इसको हम अटैच करते हैं, बाद में आपको बताऊंगा. माइक्रो कैथेटर, सॉरी वी डोंट हैव
मिडल में लगाते हैं, टिप पे नहीं लगा सकते.
वी डोंट हैव अ माइक्रो कैथेटर हियर एट द मोमेंट.
कंसोल के बाहर लगा.
totally pre-collected bar and advance.
वायर का जो एक और डिफरेंस है, दूसरी वायर से दूसरी 0.014 है, 0.09
ओ नाइन ये कॉइल जो होता है
नो इसके ऊपर लीडिंग ऑफ कोटिंग नहीं है। ये रोटा लिंक प्लस अटैच सिस्टम है जो हमने
on the table.
सो इसके जो कनेक्शंस हैं नॉर्मली जब आप इसको खोलेंगे दिस इज दो ये कनेक्शंस हैं ओके
Fiber optic network.
हम काइंडली थोड़ा सा पीछे
ये जिसे हम कह सकते हैं कि उसकी से पावर सप्लाई है बेसिकली जिसने टीवी है एग्जैक्टली ओके
हम थोड़ा सा पीछे
ये आपका प्रेशर जो हमने उस ठीक हो गया आफ्टर दैट हमने जो हमारा प्रेशर से लाइन है जो हमारा वो सिस्टम है वो हमने अटैच करना फिर फ्लश देंगे इसका सिस्टम अटैच करेंगे विद द टिप से
ये रोटाप्लॉन में तो पैडल खत्म हो जाता है ना
हाँ उसमें पैडल खत्म हो जाता है लेकिन अभी वो पाकिस्तान में अवेलेबल है लेकिन पैडल जो हमारा खत्म होगा सिर्फ उसमें से 2 जगह जाएंगे ना रोटेशंस के लिए बाकी तो बाकी से ऑलमोस्ट वो थोड़ा सा एक उसमें सिस्टम चेंज करेगा ये अटैच होता है तो दिस नॉर्मली जब हमने पैकिंग मूवमेंट करनी है तो वी डू व्हाट आई डू नॉट एट द एंड ओके इम्पोर्टेंट है ताकि ये आप इसको मूव कर सकें ये भी वायर से अटैच होता है आप दोनों के बीच में मूव कर सकेंगे So, we have attached 3 things: power, pressure, saline. It's not saline; it's a solution. Rotaglide, जो हमने खुद बनाया है basically.
सोल्यूशन सिर्फ हम ये हीट को खत्म करने के लिए करते हैं या
फ्रिक्शन को खत्म करने के लिए एंड थ्रू आउट योर इट शुड बी ड्रिपिंग बिकॉज हमने अपना ड्रॉ चेक करना है ये सारा सिस्टम अटैच करने के बाद हमने ड्रॉ चेक करना और फिर इसको विद इन द बॉडी में लेकर आना मे बी बट आई एम नॉट श्योर नॉट इन वो तो पहले ही करना उसको
जी जी श्योर श्योर
So somebody asked a question regarding कि why 300. So आप देखें इसकी लेंथ कितनी है, ओके? अगर हमारे पास 180 होगी वायर तो it would go in, it will cannot come out. So हमें उसके लिए उसके सिस्टम को उसको करना पड़ता है. आप करें इसको
इसके हार्ड एंड से करना है
तो जी
इम्पोर्टेंट थिंग इज कि आप लोग अपनी कैथ लैब में जब ये शुरू करें तो एक 2-3 लोग असाइन कर दें जो कि पहले 10-15 केसेस आप लोगों के साथ हैं. इट्स नॉट अ सिंगल पर्सन जॉब, ये 2 लोगों का काम है लोड करना और रेडी करना. एक बंदे को जो सिलेंडर मैनेज करना है. सो हैव द सेम पीपल डू अबाउट 20 केसेस विद यू. दैट वो भी कंफर्टेबल हो जाए, आप लोग भी कंफर्टेबल हो जाए उसके साथ. देन यू नो देन दे कैन टीच अदर पीपल इन दैट. बट कंसिस्टेंट रिजल्ट्स और सेफ्टी के लिए एक ही टीम को करना चाहिए शुरू.
और जॉब ऑफ योर यू नो जो आपको असिस्ट करवा रहे हैं इज इक्वली इम्पोर्टेंट. रादर व्हाट आई वुड से कि इट्स मोर इम्पोर्टेंट क्योंकि उसने वायर को सारा देखना है कि वायर इन प्लेस ना. अगर द वायर इज यू नो आउट देन इट्स आपने कैसे कर दी? ओके
इसको बोल के ऊपर कर ले. बोल
थोड़ा सा यहाँ से भी टिप होगा. ओके ये देखें इधर से भी होगा और वहाँ से भी चले नॉट ड्रिपिंग अब इसको ठीक है लेकिन मैं तो इसको ऐसे नहीं दे सकता and closest to this yes just few millimeters proximal to the distal
इसको आप अपने स्मेल ग्राफ से टच कर सकते हैं, फैब्रिक को नहीं टच कर सकते किसी किस्म की फैब्रिक को, बिकॉज वो अगर थोड़े से पीसेस पिकअप कर लेगा those will go in the artery and you can get stuck in the system also.
इसके बैक एंड से वायर आ गई होगी।
वायर वहाँ से
जो उसका बर्थ होता है उसको नहीं कर सकते क्योंकि स्मॉल पीसेस जो होते हैं उस बर्थ के ऊपर स्टक हो जाते हैं, इसलिए जैसे हम वायर वगैरह को मूव करते हैं उस तरह बर्थ को नहीं करना। कीप इट स्ट्रेट, बेसिकली एक असिस्टेंट हो जाए आपने से ओके। अब वायर देखिए पीछे से आ चुकी है, कीप द वायर देयर ओके।
इसको मैं ही पुश करूंगा यहाँ से
निकाल सकते हैं, पुल कर सकते हैं।
Now there are two things. Initially, what I would recommend, you stay here and your assistant, while fixing the wire, उसको और आप wire connector
निकाल लेते हैं।
ठीक है? Otherwise, you can do it yourself. और एक बंदा when this is moving forward, one body should be pressing the floor to see there कि wire आगे तो नहीं push हो रही when you are going in the system, कि wire तो नहीं proximally distance जा रही with your this movement या पीछे तो नहीं आ रही, क्योंकि one in pediatric procedures what they do they fix one person fixing the wire or system. Okay, so this is very important. Whenever you're doing anything more than 300, this is very important. Okay, one body should be fixing the wire.
टेबल लेंथ भी आप देखें, आपकी क्या मतलब टेबल अगर लंबी नहीं है तो यू हैव टू पुट अ स्टैंड टेबल इन द बैक ताकि उस पे वायर चीजें लटके ना नीचे।
So this dripping should happen. Dripping from here, it's very. Somebody say कि no, it's not a normal. It's a normal thing. It should happen here as well. Okay. So no.
वायरिंग बाद में करेंगे।
Before that, loading that, the workhorse wire, then the micro catheter, replacing your workhorse wire with this wire. Now this distal tip is already in the distal vessel. Okay, wire is there. Now you suppose that here is the wire connector, and this.
उसको बाद में लोड करते हैं, लोड बाद में
At this step, now you will check your draw. Okay, आप अगर इसको, okay, now check your draw there. Okay, dripping is there. Okay, next advancements. What will you do? देखिए आप इसको यहाँ से लॉक हो जाएगा, आप इसको अनलॉक करेंगे and check advancement. Now see the wire.
जिन्होंने ग्लासेस नहीं पहने हुए वो थोड़ा सा पीछे हो जाए क्योंकि स्प्लैश होगा।
It is moving up. Okay, so it is moving forward. ठीक है? Advancement. Third is rotations. Dynaglide मुंह पे ऑन किया हुआ है इन्होंने? सॉरी अगेन जब आप इसको चेक करें ऑलवेज आस्क द ऑपरेटर कि इससे हाथ परे करें, वो तो करेगा। आप इस वायर को जरूर फिक्स रखें लेकिन इससे परे और मान लीजिए किसके पास कॉटन की या पेशेंट के शीट वगैरह भी नहीं थे इसको वो करने का कौन सिस्टम चलिए इनको रोटेशन चेक करवा दो।
रोटेशन डायनाग्लाइड पे करेंगे ना,
वो आपके ऊपर डिपेंड है। ओके, उसका एक जो है वो एथेरेक्टमी के लिए, एक डायनाग्लाइड के लिए, उसके दो वो बने हुए हैं।
डायनाग्लाइड आपने 50% रिड्यूस करना होगा,
वो होता है बाय लॉ, इट्स नॉट देयर कॉजेस लो प्रेशर देयर। ओके, एनीथिंग एब्नॉर्मल देयर। ओके, अब आप देखें कि ये किस पे सिलेक्ट कर रहे हैं। डू इट ऑन द डायनाग्लाइड अफजाल साहब। आप डायना पे इसका प्रेशर कम तो नहीं है? हाँ, इसका प्रेशर कम है।
प्रेशर कम है।
So you see the pressure is around 100 to 200. So ये बड़ा इंपॉर्टेंट है कि आप प्रेशर खुद चेक करें। इसको एटलीस्ट मैं तो ये recommend 500, but if it is less than 600 आपका प्रोसीजर, क्योंकि एक प्रोसीजर में रफली ये 100 to 150 ड्रॉप कर देता है।
If it is towards the higher side, it
It's
doesn't
good.
make
It's good.
any difference. Why not to be on the safer side?
Yeah. Yes. This is the sound. अब दोबारा साउंड सुने। This is the change of mode sound. ये आपको माननी चाहिए।
ये प्रेशर है ना?
Yes. ये डायनाग्लाइड
Again we will press the dynaglide and set the RPM.
Now see the RPM while pressing the dynaguide to the wall. Again during this, this will also reduce it to 1/3. It should be there. अगर आपने outside body के check किया और इतना सा fluid नहीं है, it means it's not coming out. Foreign check your this pressure, this, and this. It should be like this.
Dynaguide can be 60-70.
Okay. So
160 and we have said 150.
yes, it's for 60 to 80, then 140 to 160 on the side.
लेकिन वो तो आपने कहा है ये
हाँ उसको नहीं छेड़ना। आपने ये चेक करने के इस तरह से है।
यहाँ हमने वो सेट करते हैं जो हमने वहाँ पर रखते हैं 160 या 140।
हमने यहाँ पे वो करने की कोशिश करेंगे।
Say for
30 cases 150 160।
150.
लेटर ऑन जब हम लोग कोशिश करते थे जब बहुत उसमें चाहिए उससे थोड़ा सा ज़्यादा एग्जैक्टली चाहिए। हमने ड्रिपिंग चेक कर ली, हमने एडवांसमेंट चेक कर ली, हमने रोटेशंस चेक कर ली,
And then
click वायर कि वायर इज फिक्स और नॉट।
क्लिप वहाँ लगा एंड पे है, इसको उतार इसको उसके पास लगा
जी इन ऑर्डर कि जब हमारा वो मूव कर रहा हो ये भी ना साथ वायर ना कर दे क्योंकि इसकी डिस्टेंस टिप उसको करेंगे इसको फिक्स कर दें। So this is not fixed. Sorry, हम वहाँ पर स्क्राइन बहुत यूज कर रहे हैं सारे काम कर रहे So this is not fixed. इसको वैसे भी रख सकते हैं
In the safe side, it's more secure.
Okay?
Right.
No, this will not.
reduce the speed to 60,000 or 70,000.
अच्छा इसमें आप इसमें देखें ये जो पूरा सिस्टम है this is bar okay this is your advanced okay this is your timing this is your power this is your what is this nobody asked ये क्या ये ब्रेक है अच्छा नॉर्मली ब्रेक कब लगती है जब उसको आप
Press करें.
इसमें रिवर्स है ब्रेक लगी हुई है जब आपने इसको नहीं दबाया ओके ब्रेक खत्म हो जाएगी जब आप इसको दबाएंगे ओके जब आपने इसको ये बाइक कनेक्टर है आपका ये अब आप बॉडी में जाने लगे हैं अब आप चाह रहे हैं कि ये इसके ऊपर जाए देन यू अनब्रेक ठीक है
Channel को हम open करें so that
एग्जैक्टली इट शुड गो सो द हैंड क्लो इज नॉर्मल इज ब्रेक उस वक्त लगती है कार की जब दबाते हैं लेकिन इसमें रिवर्स है ये अब ब्रेक दिस इज when you have reached the target then leave it don't press it you press it when you are taking the exactly no advancement ये है advancement भी says कि जब हम पैकिंग मूवमेंट करते हैं at the site of the लिए जाना चाहिए जब हमने वहाँ पे लेके जाना है उसको उस जगह पे उसके लिए हम इसको this is the brake on the wire
दोनों के on off का कुछ different है
नहीं बस आप अगर इसको दबा के रखेंगे तो ये अनलॉक हो जाएगा और अभी लॉक है
अच्छा okay fine मतलब you have to press it
जहाँ पे आपने सपोज आपने एलईडी प्रॉक्सिमल करनी है जब आप लियन से पहले जब उसका टेक ऑफ जैसे टेक ऑफ एरिया पे चले जाएंगे तब तक ब्रेक फिर उसको छोड़ देना ठीक हो गया फिर हम इसको आगे वापस जिस तरह से कहते हैं आगे ले जाएंगे
अभी हम डायनेग्लाइड से या उसको करेंगे तो ये रोटेट नहीं करेगा
जब तक आप वो दबाएंगे नहीं रोटेट नहीं करेगा वो तो
Position is
आपका
in the panel
तो फिर इस ब्रेक का क्या
ये मूवमेंट के लिए
नो जब आप अभी आप देखिए ना जिस तरह हम बैलून लेके जाते हैं ओवर द वायर अब आपने इस वायर के ऊपर लेके जाना है ये मूव ऐसे नहीं करेगा जब तक हम इसको नहीं दबाएंगे
अच्छा ये यहाँ फिक्स हो जाता है
यस आप इसको दबाएंगे और आपका जो असिस्टेंट है इस वायर को फिक्स करेगा।
अच्छा, ये इसने ये वायर को पकड़ा होता है।
यस, ये ब्रेक ऑफ द वायर है।
और अब इसके बाद
एक मिनट आप देखें, ठीक है। चलो, अब हम करें। अब सपोज हम वहाँ पे, अब आप इसे अपने अपने वो करें
packing motion.
लेकिन अब आप इसको उसको मेरा ख्याल है यहाँ रखें और एक ही बंदा ऑपरेट करके इसको करें। हाँ, आपको पता लगेगा किस तरह से, क्योंकि ये तो एक ऑपरेटर ने करना है ना। अब आप इसको ओके, नाउ फर्स्ट
ये
देखो
ये पैडल है तो ये
दिस इज यस। अब आपने अंदर जाने से पहले डायनाग्लाइड चेक करके चेंज कर दिए। ये रोटेशन ऑफ 140 to 160। नाउ यू आर एट द साइड ऑफ द वेसल। यू विल आस्क योर असिस्टेंट ओके चेक द फ्लोर,
ये ठीक है।
प्रेस द फ्लोर और सीनी, प्रेफरेबली लोटा के शूज कुछ तो सीनी में करें ताकि वो सेफ हो। वो सीनी प्रेस करेगा। नाउ यू आर सीइंग एवरीथिंग इज ओके, वायर इज फिक्स्ड, लॉक इज इन। आप इसको प्रेस करें और एक हाथ इस पे रखें और डू द पैकिंग मूवमेंट। इससे आप फॉरवर्ड जाएं थोड़ा एंड देन वापस, इससे पीछे ना जाइएगा।
और इसको मैं तब ये रिलीज करूंगा जब मैं वापस
जब वापस अपनी पोजीशन पे आ जाएंगे फिर इसको दोबारा फिक्स कर देंगे।
अच्छा, तो जो पैडल से पाँव हटाएंगे फिर उसको फिक्स करना होगा।
जब आपने पैडल से पाँव उस वक्त हटाना है जब ये अपनी जगह पे नहीं आ रहा।
हाँ वो तो पीछे लेकर आऊंगा
अपनी नॉर्मल लैंडिंग जोन पे। चलिए अपना हाथ से रखिएगा। ठीक है,
सीनी भी वो है सब कुछ है।
सीनी ऑन है इस वक्त ना। You are concentrating on this, but the assistant is concentrating on what? Two things, wire and guide. जब ये forward pull करें, wire को आगे नहीं जाना चाहिए, और जब ये forward pull करें, guide को पीछे नहीं आना चाहिए। ये ना हो कि उसको forward करें, guide ही बाहर आ जाए सारा। तो assistant is basically focusing on the wire tip and the guide, and he is focusing on the rotor कि वो जा रहा है कि नहीं जा रहा, stuck तो नहीं हो रहा।
Third session will start at 10.
Yes, go ahead.
सर इधर सामने आ जाए, आप इस तरफ आ जाए।
Yes.
यहाँ तक।
हाँ, पैकिंग इज राइट। आप प्रेस करें व्हाट आई एंड शो
मतलब फौरन उसको
वापस जल्दी आना है बिफोर टेकिंग ऑफ योर सिस्टम।
जब वापस आ जाएंगे तब भी पैडल पे पाँव रखिए।
एग्जैक्टली, जब तक आप नॉर्मल जगह पे, यही तो इम्पोर्टेंट है। अगर आपने वापस आते हुए छोड़ दिया तो स्टक हो जाएगा। पाँव अपने पे वहीं रखें।
अगर इस तरह हो जाता है फिर उसका सोल्यूशन क्या है?
स्टक हो तो पता है ना कि मल्टीपल
हाँ चलिए ठीक है।
ये लोग कोई और तो आए नहीं है, यही ग्रुप ही करना है।
चलिए ठीक है,
दूसरों से भी सुनने के बाद
एग्जैक्टली ठीक है,
वो सारे
ठीक है। जी 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 जी।
सर इसको बेसिकली हमने स्लीप में वापस लेके आना, जब हमने कहा कि हमने इसको वापस स्लीप में लेके आनी, कहाँ पे वापस, यहाँ से ये वाली
अब आपने इसको वापस अपनी पोजीशन पे ले आए। ठीक है, जब आप इसको अपनी वापस पोजीशन पे ले आए तो इसका मतलब है जहाँ से आपने इसको रोटेशन एथेरेक्टमी शुरू की थी वहाँ पे आ गया। ठीक है, अगेन इसको आप प्रेस करेंगे इनिशियली अपने असिस्टेंट को, वो इसको प्रेस करेगा। ठीक है, वायर को फिक्स करेगा और इसको बाहर निकालेगा जिस तरह OTW बैलून निकालते हैं।
सर ये क्या है? ये भी
ये इसको चेंज करने के लिए
बार अपडेट करने के लिए
अगर हमें बार चेंज, लेकिन वो एक बड़ा लंबा प्रोसीजर है, मैं तो नहीं करता। वो तो बिल्ट इन आता सब कुछ, तो आप यूज करें। चलिए मेरा ख्याल है 3-4 मिनट और देख लें, फिर नेक्स्ट सेशन है उसके बाद फिर हैंड ऑन हो जाएगा।
picking up.
कोऑर्डिनेशन मतलब ये इसमें
चाहिए वहाँ पे
आप लोग आ जाएं सीट्स पे, प्रेजेंटेशन होती है उसके बाद दोबारा फिर इंतजाम करेंगे। आ जाएं।
कुछ लोगों ने लेट ज्वाइन।
As many questions as you can. You want to go away from this session being comfortable with the setup for rotation and the indications for rotation, and then later on in the session, we'll get you to doing the hands-on as well. So the first part, we'll just go through some basics of rotational atherectomy, discuss some cases, and then sort of do firefighting back questions. Has a quick show of hands, has anyone used rotation before in their practice? Nobody? A few cases? Yeah. So a few cases. Anyone else have some experience with it? Yeah. Okay, good. Well, where do you work? Oh, I see. Okay, so you will have seen rotation before. So, what is rotational atherectomy? So this is the definition of rotational atherectomy. Basically, an atherectomy device, and it ablates heavily calcified tissue. Right? So the purpose is to debulk calcified tissue. And how does it work? It works by something known as differential cutting. Right? So if you're brave enough to put the rotaburr on the tip of your finger, yeah, so I've done this myself, it will not cause laceration of your finger because your tissue is pliable and compliant and it will give way. However, if you put the same rotaburr onto calcified tissue, it will have an effect on that calcified tissue, so it will cause ablation of the calcified tissues. And this is how it works in the coronary artery. This is a schematic, but basically it's working on the calcified tissue and it's sparing the elastic tissue. So, because one of the things that people always are concerned about is, what effect is it having on normal tissue? There's probably very little. Is to change two factors in that rotation. One is the rotor wire, and there are two types of rotor wire. There's a rotor floppy wire, and there's an extra stiff wire. And then the other thing that you can change is actually the burr itself. The burr will change in size from a 1.25, and I think it goes all the way up to a 2.5 possibly. I have to say I've never used 2.5. So most of the work that you do, you'll be able to work in the range of around 1.25 to 2.0. So it goes up in graded steps. So you've got a 1.25, which is the smallest, 1.5, 1.752. I think there's a 2.15 and then a 2.5. The shape of the burrs are also different. Okay, so if you look at the head of the burr, the 1.25 is more like a pullet, whereas the other ones are a little bit wider. And why is that important? Because one of the risks of burring, if you don't do it properly, is that you can get your burr entrapped into the lesion. Okay? And if that happens, then I'm afraid you're in big trouble. So what you need to do is try and avoid that scenario occurring. So if you look at the tip of the burr, this is basically diamond encrusted. Why have we got diamonds in there? Anyone know? Yeah, exactly. So diamond is one of the hardest substances known to man, isn't it? Yeah. And that's why we have a diamond tip, because that gives the ability to cut the calcified tissue. And when you actually perform rotation, what you're wanting to do is to do it gently. Okay? So what I always say to my trainees is, don't try and cross the lesion in one go, because you're not going to be bringing out your rotation that frequently. So you want to give yourself the best chance to have several attempts at trying to peck away at the lesion. And it's a pecking motion, basically. What you're not wanting to do is to quickly cross. You're working away at the lesion, and that takes time. Anyone know why we have two wires, the floppy and the extra support? I'd say most of the time we use in my practice I use the floppy wire rather than the extra support. The extra support is useful if you're going to do rotation in the very proximal vessels, because that will give you more support for your burr. So the only times I would use an extra support wire would be by burring a left main stem, for example, possible very deep or osteophyte. Otherwise, my default is always the most floppy wire. So this, I guess, is the old console. There is a new console that's available as well now, known as the Rotor Pro, which is sort of demonstrated over there. And what is going to happen gradually, I suspect, is that they're going to do away with this old console, and Boston Scientific are going to move to the new Rotor Pro at some stage. It's already happening in Europe, and in the UK certainly by the end of this year. All centres will have to have Rotor Pro or not be able to do rotation. So there's some subtle nuances with the new device, but I think all centres, as far as I'm aware, have this current old iteration of the device. So that's the one you can be familiar with. So this is what it looks like when it comes out of the pack. Okay, and what happens is that you have to have a good physiologist available, because they will sort out all your connections. And there's some important connections that have to be made. One is plug into the air cylinder, so you have a gas that's run on an air cylinder basis. And then you have a tachometer as well, which basically allows you to set the rotor speed. So that's something that you can control as the operator. And then you have a tread that feeds in. And we'll talk a little bit about that, I think, on the next few slides. So you then have the ability to change the actual catheter itself. So you can choose, based on what you're seeing on the angiogram, you can choose which burr you want to go for. And when rotablation first started, it's been around for a number of years, the general thought was that you should probably go for a burr to artery ratio of around 0.6, 0.7. I think things have changed now, and we'll probably aim to do a burr to artery ratio of 0.5. So if you look at the vessel, you size the vessel, you say, right, I think this is a 4 millimeter vessel, then you will probably aim to put a 1.75 or 2.0 burr into that vessel. Because there's no point putting a small burr in, it's not going to ablate the calcium, it's just going to fly through. You'll have wasted a burr. So that's the first thing you have to do. So apply common sense in terms of your burr selection. Okay, so why burr? So remember, one of the if you don't prepare your lesion adequately, then they're going to be problems. If you put a stent in, we saw some cases yesterday of underexpanded stents, and underexpanded stents unfortunately cause big problems. So there's an increased risk of stent thrombosis, and we know that underexpanded stents also cause in-stent restenosis as well in the long run. So the purpose of the ablation is to try and ensure that your vessel is as compliant as possible, so that your stent, when you do come to put your stent in, can expand adequately with the lesion. That's just the classification of calcified lesions, the ACC-AHA classification. But often when we are doing rotablation, you will hear operators talking about intravascular ultrasound. And these are sort of complementary technologies, because the IVUS will help you determine what sort of calcium modification tool you want to use. Right? So remember, rotablation is just one calcification modification tool. You've got other things available: simple balloons, non-compliant balloons, cutting balloons, scoring balloons, and then you've got other devices as well, such as orbital atherectomy and laser atherectomy as well. But I think it's probably fair to say that rotablation is probably the biggest adjunctive device used for calcium modification outside of balloons. So some images of calcified coronary arteries. Now remember, ultrasound works by the ultrasound works by causing a reflection of sound, which is then reflected off the vessel and detected by the transducer itself. Now, with calcium, what happens is that the ultrasound doesn't penetrate calcium, so you get this white appearance on your ultrasound console. And we grade calcium in a number of ways. So you can look at the amount of degrees of the arc of calcium. So here, for example, you've got 360 arc of calcium. Now, unfortunately, IVUS doesn't allow us to look at the thickness of the calcium because you don't get penetration, but you can get some meaningful information about whether or not you have reverberations or reverberations artifacts. So if you have reverberations, then there's a suggestion there that that might be thin calcium. If you don't see any reverberations, then it's probably thick calcium. So you're going to look at the amount of calcium. You're going to make some judgment on whether there's any reverberation artifact and grade the calcium in that manner. And of course, the other thing that's important is the length of calcium. So anything above sort of 5 millimeters of length is considered significant. So that basically puts you onto this thing called a calcium score. So you can grade the amount of calcium, sort of mild, moderate, or severe, depending on those parameters that we discussed already. So if you've got a 360 degree arc of calcium, for example, and it's a length more than 5 millimeters, then that would be a high calcium score. And the other thing that's important, and I think we saw some of these on the live cases yesterday, is this thing called a calcium nodule. Now, calcium nodules actually are very, very difficult to deal with because there's no guarantee when you're burring that you're actually going to be burring the calcium nodule. There are a few little tricks that you can try and work through to try and angulate the burr towards what you think or where you think the calcium nodule is. But on the whole, calcium nodules are very difficult to deal with. Okay, so that will allow you to give a score out of 4. Okay, do the any questions on that so far? So, if there are any questions, just put up your hand, just make some comments. We'll try and address those as we go along.
Questions?
Yeah, please.
Sir, the extra wire support.
Yes.
It's only for the person.
That's where I use it. I think if you're using the extra floppy wire, it doesn't give you that support that you need to be able to back out your guiding catheter. So that's why I put the extra support wire down for Austin. So Austin made Oxford made Austin wires. Because remember, when you're burring, what you don't want to really do is to burr within the guide, because you might shave off some of the inside of the guide. So you have the guide catheter backed out and have a good run into the lesion.
Sir, we can use floppy.
You can use floppy.
Safely to use extra.
Yes, I prefer in those situations to use extra support.
So, as we discussed the substrate of patients, different patients, can you see when you do angiography, definitely the patients, you see the calcium angiogram as we discussed how to grade the calcium. So, what are the patients that we should select for the recommendation? So, the important thing is we should go for the calcium scoring as we discussed in the previous slides. So, any patient who is having a calcium score of 3 or 4, these are the patients who need some modification in their vessels, are able to treat the calcium by some adjunct value. If calcium is definitely it is superficial, I will define it. The calcium is like in the inner 50% of the vessel. That's the superficial calcium. Calcium that's in the deeper 50% of the vessel, that's the deep calcium. So the rotablation is basically meant to treat the superficial calcium. So any calcium that's in the deeper part of the vessel, it becomes definitely difficult for the rotablation because rotablation is working inside the lumen. So it will be definitely difficult for the rotablation to treat the deep calcium. Then we have definitely as we discussed, we have IBL. We can use opium learning or something like that. So,
if we have no IVUS facility, then what should be the angiographic criteria for atherectomy?
Definitely, angiographically, everything you have to decide is on angiography. So, if you see that there is the diameter of the vessel. You can, with eyeballing, you can decide, as we discussed. You see that the diameter of the vessel itself is less than 3.5. You see this diffuse calcification in at least one segment of the vessel, so that definitely needs rotablation. You see that there is a tram track appearance of the calcium. That's definitely significant calcium. Tram track means you see in the superior and inferior wall of the vessel. That's a significant thing that. And if you think that the diameter of the vessel, as we discussed, that should be ideally done on the iris, but you grossly you see that your balloon assistant will not be able to cross the lesion. Definitely you need some adjunctive therapy. And if any center that's having rotablation and no iris, that's difficult to deal with such.
And to differentiate between superficial and deep
And deep calcium.
It's on iris based?
Yes, definitely it's on iris. You can also do if I think there is only one center or two centers in Pakistan which have OCT, but most of these parameters are based on iris. So definitely you decide. Nowadays, the treatment of the calcium, you have to use imaging. Without imaging, you cannot decide whether this rotablation will be effective or not.
Well, on iris, we can say that there is calcium, but superficial or deep, it's really difficult. If there is superficial calcium, no, you cannot see anything beyond this. If the calcium, so you can have some idea that whether there is calcium is superficial or deep. But if there is superficial calcium, you cannot guarantee whether there is deep calcium there or not, because you will just see the shadow of the calcium there.
Yes, because of there are some parameters on the angiogram. So if you see calcium, obviously it's fairly obvious that it's present even before you put the contrast in. But you want to be able to see it in at least two planes to determine whether there is calcium there or not. Now you can't make a judgment on whether that calcium that you're seeing is actually deep calcium or adventitial calcium or superficial calcium. But you can decide whether you can get your equipment across the lesion, which will give you some help. So let's say you wire a lesion, you appreciate there's calcium, you wire the lesion, it might feel gritty as you're putting your wire down, so that will give you some tactile feedback from your wire to say, well actually, maybe I'm dealing with a calcified vessel here. You try a 2.5 balloon, it doesn't go. You try a 2.0 balloon, it's still not going. Then you can say, well, I'm dealing with a calcified lesion here. Maybe I need to think about restoration.
And practically in most of the patients, what we are doing to go there and do the iris. So you do the rota. So in most of the cases there, we are doing rota without iris.
I mean, the Japanese basically have this thing, if they can't get the adventitia, we know that patients with diabetes or those with chronic kidney disease will have calcification. That calcification might not be within the lumen, it might be in the adventitia, in which case you don't need to replace.
Number two, the use of iris is not just for the calcification. You have to use the proper size of the stent, and you have to use the proper size of the NC balloon for such lesion.
So, how did when we come across a condition when the lesion is uncrossable, tight calcified lesion, the times we come across when the smallest balloon doesn't cross.
Yes.
So,
that would be an ideal indication for rotation.
So basically there are two major indications of rotablation. Uncrossable lesion is an indication of rotablation as well. And then unexpandable lesion, the vein which is not expanding through balloon. So uncrossable balloon cannot cross is also an indication of rotablation.
How do we compare the results of rota at times when we don't have these facilities with cutting or scoring balloons? For lesion preparation, the main objective is to debulk the calcium.
Yes.
Prepare the lesion. Overall,
well, I would use a non-compliant balloon in my practice in that situation. So let's say you've got a lesion, you think it's calcified, you go ahead, you perform rotation to that lesion, and then you use a non-compliant balloon to see if the non-compliant balloon is expanding within the lesion. Right? And you do that probably in two planes. And if you've got good, adequate expansion of your non-compliant balloon, then it's probably fair to say that you adequately modified the lesion enough to be able to think about the stent.
Generally, in our practice, in my practice, when we have come across such calcified lesions while earthing into the NC balloon, the main concept is the length of the calcium is longer. The longer the balloon, the lesser the chances of perforation and complications. So, what do you suggest in such situations when you get calcified?
I mean, I've not seen any data to suggest that, but if it's a short lesion, you probably want to use. I mean, I tend to use 15mm balloons. The question is whether you want to have direct impact just on the lesion itself, in which case you might want to use a shorter balloon, maybe a 12mm in that situation.
And then you've got a long diffuse lesion. You've got somewhere around 20-25 mm length, calcified lesion, and you don't have the facility to do it over there.
You don't have the facility to do it over there. Then you should send to somebody who does. You should never, I mean, you know, the message that we're trying to get across here is about safety, isn't it? Safety for the patient, because the patient is the person who's at the center of all of this. So, you know, you shouldn't be doing a lesion if you don't have the equipment. And not all hospitals will have those patients. So even in my country, you know, we get cases from other centres where they say, look, we can't deal with this. You know, do you mind taking this case on? You know, and there's no shame in doing that. Because if you don't have the equipment, you put an underexpanded stent into a vessel, then you're asking for trouble. You know, that patient will be back very quickly with stent thrombosis and an infarct.
So my question, when there is both superficial and deep calcium,
yes.
As you told earlier, ultrasound waves will not pass from the calcium phase.
Yes.
Then there is any criteria from the IVUS how to differentiate the calcium which is present in the media or deep calcium?
Deep calcium.
Or did you determine on the OCT?
No,
or some other imaging?
Yeah. It's quite a complex question, but basically, I mean, the main imaging modality you have in Pakistan is IVUS. Right? So let's talk about IVUS. So in IVUS, if you've got just superficial calcium, so if you go back a couple of slides here, of that view. Okay, so here you've got the IVUS probe, and you've got this is calcium, right? Can you see that? Now this is what we call superficial calcium. Now your IVUS images, well actually it does seem to have penetrated a little bit here, but on the whole, the IVUS won't penetrate through here. Now you don't know how thick this calcium is, right? The IVUS won't be able to tell you how thick this calcium is. Right? It's impossible for you to know how thick this is. You can get some clues about the thickness based on whether you can see reverberation artifacts. So if you see reverberation artifacts, by reverberation artifacts, you basically see a line, several lines here. Yeah, that tells you that the calcium is probably thin calcium, not thick calcium.
In the presence of superficial calcium, it becomes difficult to say whether the calcium is present or not. But that's an indication of the rotablation.
Now, let's say you have superficial calcium. You have no calcium here. You've got a lesion, and the calcium is out here. Well, rotablation is not going to have an effect on that, is it? Yeah. And that's the scenario that we're talking about. You can have that situation, particularly in patients with chronic kidney disease or diabetes, where they have deep calcium. The lesion can be treated without the need for adjunctive calcium multiplication devices.
So I would like to say that these are theoretical things, and if you proceed more to the practical steps of the rotablation, that will be much better to.
Yes. Stop asking questions then.
No, let us get on theoretical things, and these can be covered from the
you
books.
must have seen all these slides in the previous session, so we can just skip few of it. If there's any practical we can discuss that.
Okay. But yeah, don't worry, you'll all get a hands-on.
We will come to this. No problem. So you have been through all these in the previous session definitely. So What are the adjunctive, measure that you should take in these patients? If the patient is like high risk patient, patient who's already having first degree or second degree block, so definitely you think about the pacemaker. Other patient that is not the only way. So these are other patients who can like develop blocks. So you should think about the pacemaker in such patients. And also hemodynamic support if patient is like you're doing on high risk patient, post cabbage patient. You are doing it on the left hand, so definitely you should be ready for any hemodynamic complications. And the important thing is that you should definitely select the appropriate burr. If you select a small burr, the chances of entrapment are more. And definitely if you again take a larger burr, again the chance of entrapment will be more. So you should select the proper burr size. And the next step definitely you will engage your target vessel. You go for the like normal angioplasty. If you are not able to cross with the rota wire floppy, then ideally you should use any normal workhorse wire, and then you can exchange with the magnet. And the type of wire, as Swafan mentioned, that if you're going to for the rota ablation, you're going for the left mid or any proximal vessel, so you should ideally use high support wire that you could disengage your guiding caster. And for other lesions in the middle, distal vessel, you can use normal wire. So the available burr sizes you normally use 1.5, 1.25, 1.5, 1.75. The compatibility with the guiding caster, you should select the guiding caster accordingly. For the 6 French, you can use 1.25, 1.5, 6 French, you can use comfort. And for the 1.75, you should ideally take 7 French, and for any size that's bigger than 1.75, you should ideally go for the 8 French guiding caster. So definitely in any, if you're doing any plastic, so these are the some simple measures you should be taking. Like you should have a supportive guiding caster, there should be coaxial alignment, and you should avoid any pressure damping. These are steps that we discussed how to proceed with the wire and atherectomy. And the solution that we make, all of you must be having some information about that. We like after nice snack, we put nitrogen and paracetamol to prevent complications like stroke and no flow, and to reduce the friction. So some steps that you should do, some important measures before going for the rota ablation. The abbreviation of drip should be used. The abbreviation of drop should be used. Draw in which DRAW. You should, because we have abbreviated that it should be easy for you to remember. You should look for the, if you are connecting the rota ablation you started, you will do it on the angle and you will check whether you are having any drip from the tip of the burr or not. So this is an important step. We discuss the income, practically we'll do that and we'll see. So you should see the fluid is coming out of it or not, there's a drip or not. Number one. Number two, you should check that your rota ablation is working properly or not before proceeding the burr inside the guiding caster. You should check it outside. You will put your, you will press the pedal to check whether it's working on direct line and rota ablation or not. Number two and number three, you should check whether there is it's properly connected with the this advancer knob or not. You will check whether it's moving properly or not. And the fourth thing is you should look for your wire that you have discharged out properly, and you also have engaged properly on the back of the advancer. So, any questions regarding the preparation of your inventory? Packing motion जब मेथड आएंगे we'll definitely practically we'll go for this. So this is the case. You can see there is severe calcified lesion in the circumflex.
Sir, one question.
Yeah.
If you, let's suppose in this case we are doing rota ablation from left main to LAD and we have a significant lesion in the osteal sulc as well. So what to do? we keep a wire during root ablation, or we don't keep a wire in the side?
Yeah, so that's a challenging scenario. So you have to take out any extra wires when you're doing rotation, because what you don't want is for the rotor burr to shear the wires that you have in the side branches. So, there is a technique to try and deal with that. It's known as there's a protection technique basically where you put a microcatheter over the side branch wire or pinhole motivation. So that is,
from another guide.
You need a second guiding catheter. You have what your workhorse wire in the circ. Let's say if you want to wire rotor the LAD, you put a microcatheter over it, and you can rotoblate the LAD and still protect the circumflex at the same time.
Yes, situation when there is critical circumflex disease, there's the dominant circumflex. So again, the concept of differential cutting. So if you put a wire, that will be then definitely rotor. If you put a microcatheter, there's some reduce off. So
if you want to read about that technique, we published this last year, I think, in Archer.
So you can see in this video, so some steps. So this is the packing actually movement, you can say. You should not force the rotor, and you should not cast the lesion in one go. You to slide the knob and gently, and you should not rotablate for more than 10 seconds. And each time you have to hit the lesion and come back. You should not cross the lesion. So this is the concept of packing.
Just have a look and see if that video once again is quite nice, isn't it? So here, the other thing you spot is the temporary pacing wire. You see that? I mean, I have to say, in my practice, I've pretty much moved away from putting a temporary pacing wire in patients. Although the company will still recommend that, particularly on the arteries. So this is the pecking. This is the pecking motion. Yeah. So this is quite a large sized burr, and we're just pecking away. And as I said, don't just do it in one go. Take your time.
How to get out of the situation once the burr is crossed the lesion and you're stuck there?
Yeah, we can talk about that once.
Yeah,
Once we're on a practical session. So, very quickly, so this is your console, and you will get your physiologist to set the speed that you want the rotor burr to go at. Okay. So the first thing, do you want to all come around now? We can start the practical session.